Today's course topic is Women in Exercise. We'll be talking about considerations for the female across the lifespan, from adolescence to pregnancy and postpartum, all the way through menopause. My name is Dr. Sarah Zigley. I am a doctor of physical therapy, and I am also an orthopedic clinical specialist. I've been in practice for 11 years. My original background came from outpatient orthopedics and sports at a hospital-based system, a level 1 trauma center, and a hospital system that had the basis for professional athletes, college athletes, kind of everything from the weekend warrior up through Olympians. So after 8 years of clinical practice in that setting, I did some time in academics, being an adjunct faculty at 2 different programs, one in Wisconsin and another in Louisville, Kentucky. I also began my own practice at that time, where I started an orthopedic and a runner's clinic in Louisville, Kentucky as well. Since then, I have relocated to Wisconsin. I'm currently presenting to you from Oshkosh, Wisconsin, where I have my outpatient clinical practice as well as a consulting business where I go into other types of companies and businesses for preventative wellness and workplace health, as well as the runner's clinic and outpatient orthopedics. So that is my clinical background. Today does have course notes available on cheapceus.com. So if you'd like to have printouts or PDFs of today's course content, you're going to go back to cheapceus.com. You're going to go to continuing education courses, click on your profession, just like you did to find today's course. Once you scroll downward towards the bottom on that alphabetical list, being that we're talking about women, there will be a little icon over to the right that says click here to open notes. That orange icon is going to be where you will find today's course notes. So that brings us back to today's course and some of the more course-specific information, and soon to dive into the actual content of our lecture today. The course overview is just that Women in Exercise is a real lifetime interactive webinar for rehab professionals. We're going to examine female-specific considerations for exercise and rehab during the phases of adolescence, pregnancy and postpartum, and also menopause. It'll review the current literature that's related to women's health at these key points in the lifespan, some of the clinical implications, and then the rehab considerations that go along with it. The academic rationale for that is the purpose to provide participants with contemporary information and comparative analysis of physiology and clinical presentation so that we can understand rehab considerations and maximize outcomes based on current research. So this is, again, our academic rationale. If we're really looking at why is it that we chose this topic, I chose this topic to talk about today, it's because I feel like, even as a woman myself and a female rehab provider, there are so many nuances of treating the female patient that really got left behind in my education up until now. Sure, we had a women's health segment in our PT program, or I had subsections of my population in my clinicals where I had representations of pregnancy and postpartum. But I felt like there was a lot underlying these topics that really could have helped me to treat this population more specifically. And as I go through each of these phases in my own life as a patient, I realize how many more things I could be doing to optimize that piece. So again, I've been through adolescence myself. I've had 2 children myself. I have not yet been through menopause, but I feel like as we go through these phases, the more scientific basis we have to understand how exercise varies during each of these phases, the more we can appropriately treat the women that come through our doors looking for our help. The goals and objectives are written out for us here. We will go through all of them today. However, I'm not going to read all of them to you today because they are available if you'd like to reference them. Just our classic disclaimer for the application of the concepts presented in this webinar: they're at the discretion of individual participants in accordance with our federal, state, and professional regulations, and there are no conflicts of interest either for myself or the provider of the course. This friendly little hexagon in the corner, the consider this icon, that is going to remind you that whatever is on that slide was pertinent for the post-test. So if we're going through a slide and you notice one of these little hexagons, you're going to want to bookmark that slide in order to give us answers for the post-test at the end of the course. Adolescence, let's dive in. So we're going to start with the physiological markers of adolescence. During female puberty, we have a period of rapid physical change. There are endocrine and somatic developments that happen along these years. We also are at the end going to have the hallmark, which is reproductive maturity. Although this process may begin around 8 to 11 years old, the process is actually going to continue for 4 to 5 years before we reach that ultimate landmark of menarche. Although there are a lot of somatic and endocrine changes that happen, we're also going to have changes in other systems as well, including regulatory competence and decision making, as well as mental health. So the social and cognitive and emotional changes that happen during this period are just as rapid and just as influential as those that happen in the physical presentation of our young women. The physical stages, though, do have some ways that we track this over time. One of the most common ones is what we call the Tanner stages. Those are going to be based on the physical appearance of sex characteristics. So from stage 1 to stage 5, it is the prepubescent period all the way up until complete maturation. That stage 1 is going to graduate to the initial development, which is going to further its way all the way up until complete maturation when a female approaches menarche. And these, once again, are based primarily on visible sex characteristics. There are many of them to choose from. They don't happen in exactly this order every single time. However, there's some that are typically on the earlier side, and there are some that more classically happen towards the end. So things like breast development and general height and weight growth are often towards the beginning of that adolescent period. However, once we get towards the end, we're going to see things like the growth plate closure and the body composition, the fat distribution starting to change, with truly the ultimate final marker of this process being the onset of a young woman's menstrual cycle. Estrogen is a huge factor during female adolescence. Not only is it increasing, it's skyrocketing. So when we look at the numbers at the bottom here, the levels in adolescence of estrogens are 4 to 9 times higher than they are in childhood. So this is a major change in the hormonal levels that are happening in these young females that are giving us effects like breast development and fat distribution, the long bone growth, and the ovulation and menstruation initiation. When we're talking about estrogens, estrogen is actually a class of hormones, not one specific one. So estradiol is a specific and common estrogen, and that's the one that is primarily released from both gonads and peripheral tissue in this process. Menstruation does typically require a specific body weight in order to be initiated, and that weight is typically between 95 and 100 pounds. Because of this, we know that there are some socioeconomic factors that play into it. Historically, when we were talking about general access to nutrition, we saw that women who were growing up in more affluent households tended to have earlier onset of menstruation because they had greater access to food and greater access to caloric intake. So they reached those milestones earlier because they weren't as undernourished. We have seen that some of this trend might be different in current conditions because nutrition and socioeconomic status has a slightly different trend now than it may have centuries ago. Now we have more of the role of obesity in our underserved populations, which may have a difference again on that earlier onset of menopause. We'll talk about that later, of menarche if we're in these higher weight categories earlier on in life. We also know that the percent of body fat makes a difference, not just how many pounds, but how are those pounds distributed. So you need to have a certain degree of body fat in order to carry menstruation and start it. So some of our leaner, more athletic girls may actually have a later onset of menarche because of that. We also know that the amount of activity that adolescents have is different between girls and boys. We see that girls tend to have a decrease in physical activity compared to their peers and their male peers as they're in this period of time. And this really carries on even as they're adults. So it's not just young girls who start to be less active. It's also our young women who have that same pattern. This just means that we might actually need to encourage our young women to stay active through this period of time a little bit more guided than our boys do. So, this can be in multiple different ways. We can do it with free play, we can do it with sports, it can be just structured exercise programs. Any of that can help to really instill this lifelong pattern for remaining active. If we talk about the actual physical performance characteristics and how do they evolve throughout childhood and adolescence for females, let's start with the cardiovascular system. So, the cardiovascular system is going to be measured in this case through absolute maximal oxygen uptake. So, what we see is that that maximum linearly increases from the age of 7 up until 13 and 14 years old. And then once they hit 13 to 14, then it starts to decline slightly. We do know, though, that there's a big impact of training. So that means that if we are more physically active, we can have an increase in these parameters for young girls. And how girls compare to boys is actually significantly impacted by whether or not they exercise. So if we look at this chart at the bottom, there is a column of trained girls compared to trained boys. Then there's a column of girls who, and by untrained, we could almost substitute that by saying sedentary, girls and boys. So we see that in both groups, the girls have less absolute and relative oxygen uptake compared to their male counterparts. However, the sedentary or untrained girls fall significantly farther behind than girls who are active or trained. So we can decrease the disparity by having girls be more active. What about strength? So I think these are some of the really interesting ones, especially in our field when we're talking about musculoskeletal injury recovery. Muscular strength improves linearly, kind of like the cardiovascular system did, until about 15. So we're seeing that girls steadily increase in strength. It's not like we have this exponential curve in strength during adolescence. It's a lot more steady of an increase. The interesting parts, though, are the strength balances. So what we see is that the hamstring to quad strength imbalance becomes more pronounced during adolescence. And why does this happen? This happens because the knee extension strength compared to body mass increases steadily. So when we're talking about that, what that really means in practicality is that our quads are getting stronger compared to body mass. So our quad, if you think about like isokinetic testing and you compare strength to body mass, those knee extensors, those quads are getting stronger and stronger compared to how heavy a girl is. In comparison to this, the knee flexors stay about the same. So we see the quad strength compared to body weight increasing, hamstring or knee flexor strength compared to body weight staying the same. So the differential between them starts to grow. So that becomes a more pronounced strength imbalance. Interestingly enough, we also see that the hip abductor strength compared to body mass has a regression. So we saw quads going up, we saw hamstrings staying stable, and abductor strength in the hip is actually declining. So that's what some of these depictions here are at the bottom. This would be a balance in hamstring and quad. This would be an imbalance, and this would be a greater imbalance. We do know that strength is important and can be modified. So we see in the research that when they compare girls who have more strength, they have greater performance variables in their sprint times. So stronger girls tend to perform better athletically in more categories. We also know that if we're trying to get stronger, children in this adolescent period will see gains. So if they are training, they can expect about a 30% gain after a 2 to 5 month period of strength training. So it's greater than what we would expect to see in children, not quite to the extent that we would see in adults. However, it does have some performance impact if we do strength training in this population. Then we need to talk about motor control. So motor control would be some of these motor tasks like jumping, throwing, even running in sprints. So what are we seeing during this development? So that linear improvement we saw both in strength and in cardiovascular performance. We would expect that to be similar in motor control as well, with that peak being around 13 to 14 years old. At that point, we would expect it to plateau, or some people will see a decline at that point. What I think is interesting is in young boys who hit adolescence, people who mature later tend to have suboptimal performance compared to those who mature early. But for females, we actually see that in the reverse. So in women, if you are in adolescence and have a later maturation, it's actually associated with a better motor performance than girls who mature early. So having that delayed maturation can actually have performance benefits for young females. Part of this may actually factor in because of the motor control patterns that girls show both before and after adolescence. So, before adolescence, male and female athletes have similar mechanics, similar knee forces during a landing task. So, if we're looking at a girl doing a giant leap and we compare the forces that are happening in the motor control programs, boys and girls would look pretty similar prior to adolescence. However, following the onset of puberty, girls tend to change the way that they land from jumps. And the things that you'll see that are different are ones listed out here and probably raise a few mild red flags for us. So things like more valgus loading, increased quads while decreasing our hamstrings, decreasing the knee extension moment, and decreasing the hip flexion moment and angle. So before adolescence, these things aren't as much of a factor, but after the onset of puberty, we start to see this pattern. Now, why are the red flags raised for those of us who practice in orthopedics? Because the biomechanical risk factors for an ACL tear align pretty similarly with those that we just saw in the difference in mechanics between females and males. So again, ACL factor tear rates come from more extended knees at landing, increased abduction knee angles at initial contact, things like reduced pre-activation of the hamstrings. Because of this, not in a vacuum, but as a factor, we see that females have 4 to 6 times higher rates of ACL tears than their male counterparts in an activity matched setting. So that means if we compare downhill slalom racing females versus their ski race component males, they are going to have 4 to 6 times higher rates. If we compare competitive female soccer players and competitive male soccer players, that's what we're seeing, 4 to 6 times more likely in the female athlete. Now, while these mechanical factors are part of it, we do know that it will be multifactorial. So hormones may play a factor. Anatomy may play a factor. These other things are compounding that to really create this overall discrepancy that we see. The non-contact ACL injury, we could almost call it a pseudo epidemic, right, amongst female athletes. If you're on the sidelines of pretty much any soccer field, any female basketball team, it's not rare to see a pair of crutches and a knee brace. And how this plays into actually the hormonal part is still a topic of a lot of research. So, what they've identified so far is that we know that there is a role in the menstrual cycle when it comes to ligamentous laxity. So there is increased joint laxity that they have found during an ovulatory phase of the cycle. And we know that ACL tears are more common during the pre-ovulatory phase of the menstrual cycle. So although we've seen these trends and these associations, to date, they still have not been able to actually verify any causative factors within the menstrual cycle. So we don't necessarily know whether there are any factors that we can attribute these patterns to, and whether there's any way we can intervene according to that, right? We don't have details on really concrete recommendations for should we be practicing different at different points in the menstrual cycle? Should we be treating our athletes varying depending on where they are in their cycles? At that point, that's kind of the next phase of where research is hopefully going. But right now, we don't have concrete recommendations for that. There is also some evidence between oral contraception and laxity of the ACL, but again, not necessarily in a way where we can utilize that data to actually intervene. We just know right now that we have some associations between the cycle, the hormones, and joint laxity. We do know, however, if we're looking to intervene to try and reduce our female athlete population for their risk of ACL tear, that there are prevention programs that show high degrees of success. An ACL injury prevention program has been shown to reduce the risk of having an ACL tear in athletes by 64%, right? That is a massive amount of ACL reconstruction and ACL injury that we could be sidestepping by trying to intervene beforehand, being that preventative wellness approach. Sometimes that can be a hard sell in American healthcare and sports world, is to try and be preventative. But if we can get that message across that there is 64% less chance of having a now very high profile injury, I think a lot of people will listen. What do we know about these programs? What do they need to include? They should be multifaceted. So there should be at least 3 different types of exercise. Of those 3 different types of exercise, the 2 that should be included are plyometric and strength. If those 2 are there, then that third can fluctuate, whether it's flexibility, whether it's balance. There can be other types of training mixed in with it. We know that it should begin early, but not phase out early. So we want to have this start preseason, but also continuing throughout active play. We know that it's better if we give some emphasis on that feedback of technique. We want not just to be doing the exercises, we want to be doing the exercises well. We want the girls to actually be knowing why it is they're landing certain ways, how it is that they can modify that, and really trying to be specific with their sport that they're playing. So if they're playing basketball, we should be doing cutting, pivoting, change in direction types of things. If they're playing soccer, right, we should be doing things that are including some uneven surfaces, stuff that is going to be representative of their sport. It's also great to improve compliance if we can get both the coaches on board and the parents on board. There is also some sex-related difference when it comes to concussion. So what we know about this right now is that females actually report a higher incidence of concussion. Why this is has a few different hypotheses. We don't have one concrete reason why this might be. Part of it might be a reporting bias. Women might be more likely to report their concussion than men are. Could be anatomical. Maybe the actual muscles of the neck or the structure of the neck and shoulders might be part of that. Could it be hormonal, that there is a component of that on the brain itself? Or could it be demyelination sex differences? So all of these have the potential to impact a woman's likelihood to have concussion. When they report the concussion, we also know that there is a higher severity index. So they give them these questionnaires of all the different symptoms that you can have during concussion and then how severe are they. Women report higher indexes of symptom severity. But interestingly enough, although they're reporting these more severe symptoms, the recovery trajectory seems to be fairly similar between men and women. So overall recovery seems to be similar. Then that brings us to the female athlete triad. The female athlete triad is the concept that was developed back in the 1990s. And it was really this connection between energy availability and disordered eating, the menstrual cycle and dysregulation of that, and then having bone density issues, and how those three factors often overlapped in the population of the young female athlete. This has been revised over time as they've come to identify that it's not just disorder eating, but it can also be any kind of mismatch in energy availability. And knowing that you can have one component of the triangle without necessarily having to have all three. We're going to go through each peak of the triangle, each corner, and just talk a little bit more about them so that we have a better understanding of how they factor in this population. So let's start with menstrual dysfunction. So we're going to talk about three different types of menstrual dysfunction. We've got primary and secondary amenorrhea, and then oligomenorrhea. Primary amenorrhea is referring to a delayed onset of the menstrual cycle. So if a young girl makes it to 15 years old without having a first period, that would be considered primary amenorrhea. This varies from secondary, where a young woman has a period onset, but then at some point the period disappears. It stops happening. So if there's a cessation of those regular menses for a period of 3 months, or if an irregularity persists for more than 6 months, that would be classified as secondary amenorrhea. And then oligomenorrhea is truly the irregularity itself. So if the cycles are more than 35 days apart, that would be considered oligomenorrhea. And in this age group, they actually redefine that a little bit by having it more than 45 days apart, because that early period of adolescence is more likely to have that kind of irregular cycle to begin with. So that first 2 to 3 years, it's defined more like 45 days, and then going down to 35 once you're further into a regular cycle. There are different causes for the menstrual dysfunction. The one we're going to talk about is called FHA, or functional hypothalamic amenorrhea. This is really the kind that comes from having low weight or excessive exercise or stress. But it needs to be a diagnosis of exclusion, because there are, of course, other reasons why there could be an issue with this, whether it's reproductive organ problem, or different hormonal ones that are not related to growth. So we need to really look through some of those potential causes before landing on the FHA. This does account for a much greater proportion of secondary amenorrhea, which is the kind where, again, there's initially an onset, but then it stops, compared to primary. And the reason for that comes from the difference in requirement for fat storage. So it actually requires a higher degree of body fat to maintain a menstrual cycle than it does to initiate it. So in this case, we have on the slide as a reference, there is a 22% body fat that's required to maintain a menstrual cycle. However, to get your first menstrual cycle, you only have to hit 17. So that's why this kind of reduced low body weight excessive exercise tends to hit that secondary amenorrhea first. So, not surprisingly, we see higher incidences of this in athletics that emphasize the body weight and aesthetics, things like runners, dancers, gymnasts, and figure skaters. Another corner of our triangle is bone mineral density. And this period of life is incredibly influential for bone mineral density and overall lifetime of bone health because 25%, so a quarter of all of a female's bone mass, is accrued in just 2 years of our life. A quarter of our bone density happens in just 2 years around the onset of the menstrual cycle. And our bone density hits 90% of its peak by the time we're 18 years old. So we really have to emphasize what's happening with our bones during this period of teenage and preteen years. Estrogen plays a factor in this. So if we have low estrogen, it can actually impact our musculoskeletal health because of its impact on the balance of osteoblasts and osteoclasts. So if we've got this osteoblast osteoclast imbalance, then we'll get excessive breakdown of bone versus the buildup. And that's part of what we need to try and mediate by having appropriate body weight. It's not just body weight though, it's adequate nutrition, overall energy availability, and nutrients. However, physical activity and weight bearing exercise also needs to be at just the right amount, right? Not enough and we don't stimulate bone growth, too much and we exceed that threshold and we start to break it down. So we're really looking for that moderate amount of physical activity and then having this adequate nutritional support to really balance out growth. Unfortunately, if we're not on the right side of that balance, either because we have low estrogen or we're excessively exercising too much, we can have decreases in bone mineral density, which lead to weaker bone and an increased risk of injuries, including fractures. Depending on how long this process goes on, unfortunately, it can have long term implications. So it's not like if we're 15, 16 years old and doing this, and then realize as a young adult that actually maybe we need a healthier balance. Sometimes it is too late to fully get restoration. So we really need to make sure that we're catching these things early and intervening early so that we don't get some of this residual deficit that can happen if we do not have adequate bone density early on. This is that transition then that we saw from the female athlete triad to Red S. Red S meaning relative energy deficiency in sport. So the need for this came about by the discussion of, is it really that we have to have all of these components of the triangle, or is it that if we have relatively insufficient energy for the amount of activity, are we going to see consequences regardless? And on top of it, Red S, it does apply to females just like the female athlete triad did, but it also recognizes this isn't a universally female only condition. Men and young boys can have this problem as well. So Red S was more inclusive across the scale. We also started to recognize more of the performance and external physiological impacts of it, which we'll go into a little bit more on the next slide. So, of course, physiologically, we see things like poor bone health and metabolic issues and cardiovascular impairments. There are things like GI dysfunction and menstrual dysfunction as well. However, sometimes the things that resonate more with the patients themselves or with the athletes themselves are these performance characteristics. So, of course, a lot of what we do as rehab professionals is not just put together this clinical signs and symptoms and sequelae and risks and benefits, but is trying to communicate to our patients on what the actual cost and benefits of these different conditions are. And I think by having performance related impact, we can actually have a little bit more successful conversations with our patients about what this might mean for them, not just physiologically, but in terms of, at this age, oftentimes one of their primary goals. So it's things like decreased training response, impairments in judgment or coordination, concentration, and then some of the other things that are more psychosocial, like irritability and depression. We also see decreases in endurance. Interestingly enough, some of the people who are at highest risk still don't really understand this concept. So they've done some studies where they looked at general knowledge about low energy availability in sports and who is really well versed in this and who really isn't having these conversations. And I think, not surprisingly, our athletic trainers had the highest baseline understanding of Red S. However, the lowest understanding came from female athletes in cross country. So this, of course, is one of our populations that's at very high risk, being that runners often are trying to emphasize that leaner body mass. So some of these really high risk athletes really aren't well versed in this issue and might not be looking for it. So this gives us as rehab providers really a window of opportunity to catch things that might otherwise fly under the radar. We also know that there are additional long-term effects, kind of like we were talking about with the bone density and how it can be hard to catch up. Low energy availability also can have an impact on the cardiovascular system long term. So it can be a factor in endothelial dysfunction, and it also can be a marker for future cardiovascular risk. In addition to that, we also see potential detrimental effects on future reproductive health, and all of these things are stemming again from a period of the women's life where they may not be thinking about these things down the road. So as adult rehab providers, these are things that we can help to, again, kind of bring to the forefront as reasons why we should care now. And then the final topic I just wanted to spend a little time on today in this population is early sport specialization. So early sport specialization is defined here using this little Venn diagram on the right as either low, moderate, or highly specialized based on how many of these you have. So focusing on a single main sport is one, year-round training is another, and then essentially getting rid of all other sports in order to pursue a single sport. Those are the three factors that go into a level of early specialization. We'd like to say that it seems like it's more popular to specialize than it was 20 years ago. However, they didn't even study this 20 years ago, which probably in and of itself is evidence that it has a different role in today's society than it did then. The professionals dealing with pediatric health have kind of all come together to say that they discourage specializing in a single sport before the age of adolescence. So that means our 7 or 8-year-olds shouldn't be focusing all their effort on just one sport. We should be seeing these kids trying many different skill sets, seeing many different motor programs, many different activities until they're in adolescence. There is a very specific ratio here that is recommended, that it's a 2-to-1 ratio of hours spent in time on free play compared to an organized sport. And that should be a 2-to-1, where if we're out practicing, let's say, gymnastics for 5 hours a week, that means that a child should have at least 10 hours a week of free play. So again, just kind of giving that balance for what it should look like during this period of time. We do know that females are more likely to have this sports specialization concern in some specific sports. So part of this comes from the type of sports that women are more likely to play. So we know that women are more likely to participate in individual sports than men. And these individual sports have higher rates of early specialization. So we're talking sports like golf, sports like tennis, sports like gymnastics, where they're more individualized. These sports also have higher rates of overuse injury than more team sports. But when we're even connecting or comparing boys and girls, again, in age and activity match, so that means if we're looking at boys who play tennis and girls who play tennis, the girls are still more likely in those matched groups to have overuse injuries than their male counterparts. I like this chart. I wanted it in your slides for reference because I think it's a really great thing to show either coaches, parents, or to use in your own recommendations for your patients. It's talking about really how do we stay within that healthy balance of sport specialization. Part of it, and these are organized by level of evidence. So starting at the gold being the best and kind of working our way down where it's more the panel expert recommendations. So the highest level of evidence is for preseason and in-season conditioning and fitness program with a focus on injury prevention. From there, we're coming down and getting more recommendations related to the number of hours that should be spent for a given week based on the age. And for example, it says in here, one of them is that the total hours of organized sports per week should be less than the child's age in years. So that means that a 5-year-old shouldn't be spending more than 5 hours a week in organized sports. 10-year-old should be spending 10 hours or less in organized sports a week. When we get down to this last category, they're talking more about time in between sports, thinking about having some time off in between seasons or having a little bit of time in between each end before starting again. So again, I think a great reference table for us to have as we're working as advisors for either coaches, parents, or patients. And then we'll finish just with a little case example. So this is someone who I worked with in the clinic about probably 5 years ago. At the time, she was 18 years old. Well, I didn't see her actually at 18, but this is the beginning of her story. At 18 years old, when she was a senior in high school, she was a varsity soccer player and suffered a non-contact right ACL tear during a game. She had a reconstruction done, and at the time actually had an allograft, which is kind of an unusual selection for an 18-year-old with a primary ACL. But at that time, she went through, had a successful procedure, and completed a full course of post-op rehab. She was able to return to sport, including rec soccer, when she went on to college. Then 5 years later, so now at 23, she suffered a non-contact ACL tear on the left side. This was during a rec soccer game and again had ACL reconstruction, this time actually with a different surgeon, and they opted for a hamstring autograft. So she went through a full course of rehab this time as well and was able to return to sport. So 3 years later is actually when we met. So now at the age of 26, she suffered a repeat ACL tear of her left side. So this was a non-contact injury. She was just doing a cardio exercise class, was doing some shuttle runs, changed direction, and lost the ACL on that side. She had a revision reconstruction on that side, which now was using a patellar tendon autograft, and completed a full course of rehab with me that time around, that time returning by choice to lower risk exercise. I think this example specifically kind of brings up the female athlete risk. So we know that she had a mother who also had ACL deficiency and an older sister who had had an ACL tear and reconstruction. So likely genetically, her anatomy was probably different. She was playing these higher risk sports, but she had gone through all of the rehab and done all of the conditioning and all of the retraining that would be expected to go back to sports. So I love this picture here because I feel like sometimes when we get athletes in this this trajectory, I feel like this is probably the only way we'd really feel safe sending them back, because although she has great mechanical recovery, she has good strength or balance retrained. Sometimes we just have some of these predisposing characteristics that really set us up for a high risk of ACL. And actually, now that I think about it, this patient actually just reached out to me about 2 months ago saying that she was jump roping and had a potential re-injury of her ACL. So again, sometimes these anatomy and predisposing factors just are working against you, especially in the female athlete population. Pregnancy and postpartum. So the physiological changes with pregnancy are probably some of the most pronounced because they're visibly so much different than some of the other phases, most notably being weight gain. So during pregnancy, it's a time where weight gain is a very pronounced factor. So we want to kind of talk about how does this really factor into joint forces. So we've seen in the research that a 20% increase in weight can increase the force in a joint by as much as 20%. So really, it's not proportional. It's not 20% more weight, 20% more stress on our joints. 20% weight, 100% in joints, up to 100%. Some of the joints most impacted by this include our low back, our SI joints, and the pelvis. We see this increase in lordosis that happens in the lumbar region, as well as that increased anterior tilt of the pelvis, and some increased laxity around the SI joints. The ligamentous laxity is really something that we should talk more about because it is related to this transient change in hormones. So, relaxin is associated with the remodeling of collagen fibers. So, collagen being a huge contribution to ligamentous support as well as our tendon support. And as we're going through the process of pregnancy, there is an increase in relaxin. This happens actually really early in the pregnancy. I think sometimes we don't realize how soon some of these changes really happen. The values are increasing up until the 12th week. And then after they peak, they decline until about week 17. So, really, we've got this really first trimester peak in relaxin that's then going to kind of subside to about 50% of that peak and decline until about 17. This means that some of the changes related to relaxin's effects are going to also happen early on. Things like pubic symphysis widening already are happening at weeks 10 to 12. So, again, even though someone may barely be showing at this point, they're already physiologically adapting and getting ready for not just the growth of the baby, but the delivery of the baby. We see hemodynamic changes as well. So, really talking about the cardiovascular system. We have an increase in the circulatory reserve. This has dual purpose. It's both to sustain the woman as she's doing more physiologic work to grow a human, but it's also to support the actual fetus, both at rest and during periods of exercise. There are multiple characteristics that are changing, most of them for the increase. Things like blood volume and heart rate are going to increase. Also, stroke volume and total cardiac output. There is one factor on this list that is decreasing, and that's our vascular resistance. So, overall, that system is working together to adapt. We do see it as a overall kind of detriment to the system that we do see edema and soft tissue in up to 80% of women. So, although the system is working in many ways to try and support and augment the growth, we do have some ways in which it has difficulty keeping up, like that soft tissue edema. Probably most classically described as the swollen ankles of pregnancy. From a pulmonary perspective, we also see an increase in minute volume. This is increasing by 50% and primarily due to increased tidal volume. If, like myself, you're not really practicing in cardiopulm all that often anymore, I feel like this chart can be kind of helpful to freshen that up again. Tidal volume being this little one here in the middle between your inspiratory reserve volume and your expiratory reserve volume. The question really has always been historically, should pregnant women even be exercising? right? There was a time where women in pregnancy were considered very fragile, needed to be resting and just kind of sitting back and letting things happen. But the question really came down to, is there a risk at that point? So they've done the research and look at this list and found that exercise does not increase the risk of miscarriage or fetal growth issues or musculoskeletal injuries or premature delivery. So, really, a lot of those risks that maybe were presumed to be present with exercising in pregnancy haven't been a factor. And really, in contrast to that, quite strongly, is the fact that inactivity or excessive weight gain are actually risk factors for obesity and maternal complications. And one of those being, importantly, gestational diabetes. But not only have they ruled out that exercising in pregnancy is risk laden with risk, they've actually found that it's beneficial to exercise. It's not just a lack of risk, it's actually beneficial. And these are some of the ways in which exercise has been found to be beneficial. So, one of them being decrease in the excessive gestational weight, decrease in gestational diabetes, decrease in hypertensive issues during pregnancy, decreases in preterm birth and lower birth weight, and decrease in C section rates. So, overall, when women exercise during pregnancy, they're at better physiologic state to have a lot of these things kind of preferential characteristics go well during pregnancy. And then the answer always comes back to, well, what about the baby, right? What about the fetus? At this point, we see that there's actually minimal to moderate increase in fetal heart rate. They might get 10 to 30 beats per minute increase from their baseline during or after their mother's exercise. But when they come down and actually look at the baby's weight, there's really not a significant difference. If there is a difference, it's minimal in the birth weight of babies who are born to moms who exercise versus those who don't. The exception to that is that women who continue vigorous exercise into that third trimester may have a baby that's slightly smaller, about 200 to 400 grams smaller, although they do not qualify this as a maternal, as a fetal growth restriction. It's just a slightly smaller baby, which for anyone who's delivered a baby probably sees that as a maybe an advantage versus a disadvantage to having the birth weight slightly smaller. So knowing that exercise, generally speaking, is quite advantageous to both the mother and the baby, we need to be talking about screening for exercise. So it's not universal, right? We know we still need to choose people who are healthy and safe and appropriate for exercise. And this is some of what we're going to talk about on the next few slides is how do we verify that people truly are in a good position to start exercise in pregnancy, knowing that the ultimate goal really is to have all of our women exercise. So these recommendations come from the American College of Gynecologists and Obstetricians. They've published recommendations that are absolute contraindications as well as relative contraindications to exercise in pregnancy. The absolute contraindications tend to be ones that are more related to the status of the pregnancy and any diagnoses of pregnancy, things like incompetent cervix, risk of premature labor in a multiple gestational pregnancy, persistent bleeding in the second and third trimester, placenta previa later in the pregnancy as well, or things like premature labor and ruptured membranes. There are other ones like preeclampsia and hypertension, severe anemia, most of them related again to the status and diagnoses related to pregnancy. There are a couple that are more related to the mother's general health, like heart disease and lung disease. Then the relative contraindications, more of those are related to the mother's general health. So we've got things like the extremes on BMI, so either under 12 or extreme morbid obesity, or things like poorly controlled chronic diseases like type 1 diabetes or bronchitis, things like that, hypertension, that's again poorly controlled. So if these things are controlled, that's where it becomes less of a concern for a contraindication. Again, a great reference slide to have, as it's directly from the American Association of Gynecologists and Obstetricians. So these are specific pre-screening statuses for the current pregnancy that can be used in conjunction with some of those charts that we had on the last page. So if we're talking about things that we should be really thinking about or clearing with an MD before recommending exercise, it would be things like looking at people who have bleeding or faintness and dizziness or difficulty with weight gain or fetal movement. Those are ones that all would be worth having this additional conversation with a medical provider, versus ones that might be a little bit more intuitive to us because of their correlation with regular everyday patients who aren't pregnant, right? Things like headaches or signs of potential blood clots. Those are things we're going to be thinking about no matter who our patient population is and whether or not they're safe for exercise. We want to take into account someone's current activity level. So if somebody is regularly participating in exercise, so if you have someone who is training for a marathon and then finds out they're pregnant, their recommendations for exercise will likely be different than someone who is baseline sedentary. This can be recreational exercise, but that can also factor in for occupational activity. If you have somebody who is lifting all day, who is on their feet all day, versus someone who has a sedentary job, those recommendations will come into play with that as well. Then smoking and alcohol consumption are clearly topics for conversation on overall health and well-being for the mother and baby in addition. The actual parameters and dosing for exercise in pregnancy have a lot in common with our other populations as well, with the exception of intensity. So when we're talking about intensity of exercise in pregnancy, there is the need to use an RPE-based scale. So a lot of exercise is dosed in intensity by using heart rate and heart rate max. In the pregnant population, we see that baseline elevation of heart rate. So our heart rate may or may not actually be an accurate predictor of how hard we're working. So RPE is a much better baseline tool to be able to establish exercise intensity. So our target being moderate exercise, which is in that RPE 13 to 14 out of the 20-point scale. If we're working with a previously active patient, those higher intensities above 13, 14 can still be safe and can still be recommended if someone is preconditioned for that. So again, our marathon runner, can she continue to run? She can, because her body was accustomed to that. Now, if you had been sedentary, found out you're pregnant and want to go into exercise, that might not be the time to start your marathon training program for the very first time. But if your body is acclimated to that type of exercise, it's verified to be a safe concept to start. Other than intensity, when we're talking about the time and duration, about 20 to 30 minutes a day, most or all days a week. So that part has a lot of overlap with general exercise recommendations as well. For strengthening in this population, it's important to really think about the tasks that their specificity of training, right? So when we're working with a football player or a runner or a ballet dancer, we're going to choose exercises that prepare them for their specific activity. When we're talking about pregnancy, we can look at it the same way as we're thinking about athletes. So there are specific muscle groups that they're going to need for tasks of their sport of motherhood afterwards. Let's go through a few of those. So their upper back. Strengthening the upper back is going to help with their postural support and also is doing preparation for holding the baby, right? So a baby might come out 6, 7, 8, 9 pounds, but that baby isn't going to stay 6, 7, or 8 pounds for very long. So having that baseline functional strength can prepare for baby holding at the beginning and also as they grow. The lower back is also going to similarly support posture, but now not just holding the baby, but lifting the baby. Babies spend lots of time on the floor on very low devices so they don't fall off of things, low in cribs. So there's a lot of lifting involved, and that can be supported with lower back strength. Abdominals is probably one that is most intuitively included in this group because of the distension that happens in the abdominal region. Not only is this supporting posture, as kind of all of the above have, but it can also have a preventative role in low back pain and diastasis recti, and also help prepare for labor and delivery. The pelvic floor is probably the martyr of the pregnancy experience. Having increase in strength of the pelvic floor can help with both bladder control and also to prevent incontinence. And then finally, when we're talking about the upper body, this can be helpful for breast support. Breast support as we're going through both the pregnancy and postpartum phases with potentially breastfeeding. The increased weight can be helpful to have increased strength. And then again, lifting and holding the baby, not just them, but all of their stuff. Babies don't just come, well, they come just themselves, but we package them with all kinds of other things, right? And that's actually what I use the next slide for. In thinking about motherhood as a sport, we've got all of these different types of, and this is just a subsample, all the different kinds of equipment that they come with that are often either picked up, carried, loaded in and out of a car, that all have substantial weight to them. For example, a jogging stroller is on average 24 to 43 pounds empty. A travel crib, maybe 20 pounds. An infant car seat, between 9 and 12 pounds empty. And then a diaper bag, maybe filled 7 to 10 pounds. So these are, again, everyday weights that a mother is lifting many, many times throughout the day, that having this strength and fitness is going to help condition them for. When a mom is exercising, or a pregnant mom during the prenatal period, there are some special considerations that we need to take into account and educate them on in order to keep them exercising in a healthy way. One of them is temperature. So pregnancy has an important relationship with temperature. One, because exposure to heat from external sources like hot tubs, saunas, or an internal source of a fever have shown associations with an increased risk of neural tube defects. So because of that, we really want to try and maintain a healthy environment when it comes to temperature. When it comes to regulation of our own body temperature with things like exercise, we know that it does not increase the internal core body temperature into this range where we'd be concerned. However, the regulatory process of the body during pregnancy with temperature isn't as efficient. So it's more important to stay well hydrated, to wear loose fitting clothing, and to avoid these environmental areas that might induce heat stress. I think nutrition is also a really important subtopic just to touch on. As a pregnant woman, the baseline energy increases in need by 300 to 400 calories. So that's just to survive. So in order to grow the fetus and maintain the baseline metabolic base, you need to have that extra 300 to 400 kilocalories per day. Now that's without adding additional exercise. So if they're doing prolonged exercise, meaning more than 45 minutes, the increased risk of hypoglycemia arises. So we need to make sure that there is adequate caloric intake before exercise, or that the duration and intensity is limited appropriately to stay within that nutritional threshold. Position is another important one. So we talk about avoiding supine. So the reason for that is that maintaining supine position in that kind of late second trimester and into the third can result in a decreased venous return and decreased uterine blood flow. That's from aortocaval compression from the uterus, actually physically doing that obstruction to the blood flow can also lead to orthostatic hypotension. So the good news is for exercise, we really have plenty of ways to modify almost anything that we would be doing. I can't really think of many exercises that aren't modifiable in some way to quadruped or side lying, even sitting or standing. Usually we just need to be more mindful of this towards the end of the second trimester and definitely into the third. If you are asked to be a resource for occupational restrictions, there are actually specific reference guides available to help guide the appropriate lifting restrictions during pregnancy. And the factors that they will ask for in order to calculate that lifting restriction will be the frequency of lifting within the job, the hours per day that are spent lifting, the height of the lift both at the start and at the finish, and how far away from the body the lift is being performed. So those things will all be factored in and be given a recommendation based on the gestational phase. So there is one recommendation for the first 20 weeks, and then there's a second recommendation for after 20 weeks. So again, if that's a part of the conversation clinically that you're involved in, just be aware that there are resources out there to help objectify your recommendations. There are some signs that we would need to discontinue exercise. Now, again, some of these are very much consistent with the general population. I would say probably all of these in the bottom two rows. So we've got things like shortness of breath and dizziness and headaches or chest pain. I don't think any of us as rehab professionals would encourage our patients to continue exercising through those symptoms. Similarly with muscular weakness that affects their balance, or calf pain and swelling. However, that top row is more population specific. So vaginal bleeding and abdominal pain or regular painful contractions, or if you get amniotic fluid leakage. These are all things that we would want to have that flag up of, we probably should be talking about discontinuation of exercise for sure, as well as communication with the medical team. For the next section, let's talk a little bit about the musculoskeletal disorders that we see in higher prevalence during pregnancy. So some of the conditions that you're most likely to encounter as the PT, OT, seeing someone during their pregnancy. The number one of these that I think comes up pretty much universally is low back pain. And the reason that is because the statistics are high. More than 60% of pregnant women will experience back pain. And in this phase, really our greatest tool is to provide patient education. So some of these types of things we're going to want to tell them about are breaks for leg elevation. So we talked about the hemodynamic changes in the edema. So by elevating the legs, we can reduce some of that. We can also, though, relieve the hyperlordosis. So when they're standing for a long period of time, we get this big lordotic increase. Taking a little bit of break to elevate those legs, not only is it going to help the edema, but it'll help to kind of offload that lordotic curve. Teaching them about pillow use for sleeping. Fortunately, at this point, commercially, there are all kinds of little helpful tools available, all sorts of snake-shaped pillows and question mark-shaped pillows that go around a mom, behind a mom, between the knees, support the bump, all of the things that might offload some of those musculoskeletal structures that are under stress. And then personally, my favorite in this category is the lifting modifications. I think one of the things that we have to really remember is that a lot of people going through this pregnancy journey aren't doing it for the first time. And for them, that may mean that they have someone quite small at home who is also relying on them for a lot of physical help. So this picture here is actually my son. He is now 7.5 years old. So this was quite a long time ago. But this was one of the tools that we had built for him, and I know are available all over the place, these little toddler towers to help us not have to lift him up so much when we were expecting our second one, who was a daughter. By having these little steps and towers, he could climb up and stand next to us at the counter without always asking to pick me up, which saved the back for the expectant mom. So things like that I think are really influential. Other things that I think about teaching toddler age kids is how to climb into their own car seat, because that lift, twist, and reach away from the body is one of the situations that I think is most stressful for moms' backs. So teaching a little toddler to be able to crawl in the car, climb up into their own car seat, so a mom is merely buckling them and not also lifting them. Another great example is in and out of a crib. If an older sibling, a toddler, is still in a crib, either transitioning them to a toddler bed or giving them resources to help them climb up and over rather than having to have the mom lift them. For back pain, we also know that aerobic exercise is helpful. Abdominal binders can be helpful. When we're talking about binders, just remember we have two different kinds. So there's abdominal binders, which are the kind that are going to sit up and above the pelvic bowl and are going to support underneath the weight of the baby. And this is in contrast to an SI belt, which is going to be worn below the iliac crest and really cinching those pelvic bones snug. So we're talking in this case about the abdominal binder, that weight supported upper body one. And then there is some potential research basis for acupuncture during this time as well. When we're looking at actual exercise-based interventions for low back in pregnancy, strengthening of the abdominals and back muscles can be helpful. And then also some of the mobility work just to kind of help offload structures that have been under constant pressure. Things like bird dogs or cat-cow can be helpful both for stabilization and mobility. The standing lateral or forward reach, again, kind of opening up the rib cage through the side, as shown in the picture there, also from the forward direction. That can be done on an exercise ball, on a wall as well. We've got lower trunk rotational stretch. So I know a lot of women really love this one, where you're laying on your back and letting both of your knees come over to the same side, even crossing over to get that kind of ringing rotational aspect of the lower back. The piriformis stretch can be modified from that supine position, of course, to sitting to be able to improve their tolerance positionally. And then pelvic tilts. And I think one of the things that is good to just keep in mind with this population is that the low level exercises in this case are actually going to be significantly higher levels of difficulty because there's always built-in resistance. So doing an anti-gravity pelvic tilt is going to be significantly harder in this population because they're actually lifting an entire human being to go with them into that posterior pelvic tilt. And then the role of the clamshell, I find that to be a really great pelvic stabilizer for anyone who's having that really low back pain, to support it through the glutes and hip rotators. That does also bring us to pelvic pain. I think pelvic pain is one that, although not as common as low back pain, comes up in this population more than pretty much any other population. Interestingly enough, if you feel conflicted about what to do when you see someone come on your schedule with pregnancy-related pelvic pain, the CPG actually supports that conflicting feeling because the clinical practice guideline actually says that there's conflicting evidence found for interventions, including support belts, exercise, manual therapy, pretty much everything at this point is kind of equivocal levels of evidence. There's not great support for any one intervention. Because of that, we probably rely a little bit more on our clinical expertise. Personally, I've found the most success in the pelvic pain patient population with isometric exercises of the hips. So doing hip adductor and abductor isometric exercises, either with a pillow squeeze adductor or a belt or banded abductor isometric, I find that those tend to have my greatest clinical implications and impact, even though our practice guidelines are a little uncertain. The support belts, I find that those can be helpful for some. One of the ways that you can pre-screen whether or not someone might benefit from that, I love using the straight leg maneuver or a march. So if you're trying to test whether someone's pelvic girdle pain might be impacted positively from a belt, like an SI joint belt, one of the things you can do is have them lay on their back momentarily and do a straight leg raise and see when they lift one leg up, do they have increase in pain? If they do, then you can take your hands and come over the top and do a compression of their SI joint or through their iliac crests and have them repeat the straight leg raise again. If you're stabilizing and really pressure putting together their SI joint and they raise that leg up and they feel better, then they may likely feel better with the use of a support belt. That same type of exercise test can also be done in standing. So if you have a patient standing in the clinic and they lift up a knee like they're marching and they have an increase in pain, then you cinch them together and you work like the SI belt, and then you have them lift up again and it feels a little better, that person is someone I'd be more likely to recommend a trial of an SI belt. Unfortunately, now these are pretty easy to get your hands on as a patient. You can order them online. You can have one to your door in a day or two without having to go through all of the hoops of insurance that it used to be when we wanted one of them. I would like to spend just a little time talking about hip pain in pregnancy. And although these diagnoses aren't particularly common, I do think that they're important to talk about because they are specific to the pregnant population. So in the course of pregnancy, two of these diagnoses that can occur are transient osteoporosis and osteonecrosis of the femoral head. So the transient osteoporosis is exactly what it sounds like from a bone density perspective, but it's triggered during the time of pregnancy. So the treatment for that would be protecting the weight bearing and hopefully just getting them safely through it while protecting them so that they don't fracture and require surgical intervention. This does vary a little bit from the osteonecrosis, where the femoral head is actually seeing that bone death. potentially from the changes in hormonal activity and the weight and intraosseous pressure, in which case we're going to restrict their weight bearing to limit the progression of it and wait until post-delivery in order to do a definitive course of care. How would you be able to identify that one of these things might be occurring? That would be from their presentation, usually in that third trimester, where they're having weight-bearing hip pain, some antalgia, but really imaging is going to be the definitive diagnostic tool for that. So again, not super common to have these intra-articular issues of the hip. However, they are specific to pregnancy and things that we should have on our radar so that if someone is coming into our office with this presentation, we can help identify it and catch it early to protect them from needing further interventions that could have been prevented. Interestingly enough, despite the young and agile reputation of this age demographic, it's actually been found that between 25 and 27%, so essentially a quarter of all pregnant women, fall, right? If you just look at this age group, so let's say 20 to 45-year-old women in general, we wouldn't expect a quarter of all of them to report falling, right? So this is something that we really need to be thinking about, attending to, educating our patients on, because we don't want to put them or the babies at risk from having injuries related to falls. Really, we don't see this happen in the first trimester. The postural stability, women aren't usually showing a lot. There's not a big modification in their center of gravity. However, in the second and especially third trimester, we do. And interestingly enough, this is also still present postpartum. So we know in those 6 to 8 weeks after delivery, some of these postural imbalances will still stay. And also, a good factor to kind of consider here is that sedentary women actually have higher rates than active women. So it might suggest that there's some protective effect from being more active. The reason that we talk about this is because there may be some need to modify activities based on fall risk. I have had patients in the past who are avid runners who became pregnant, and although cardiovascularly, musculoskeletally, they were very appropriate to continue running through pregnancy, their actual fall risk became the piece that made them have to modify to a non-impact exercise. Because no matter how well your heart's doing, your knees are doing, your hips are doing, if you're tripping, if you're falling during an activity, that's a reason we might want to switch to something a little bit safer. And then one other one just to bring up is carpal tunnel. The incidence, kind of true to research standards here, has a massive range from 2%, so only a few, to 70%, meaning most everybody. We know that carpal tunnel is more common in pregnancy than in other populations. The contributing factors, the reasons why we think this happens: hormonal changes, that accumulation of fluid. We talked about edema. There's not a lot of space in that carpal tunnel, so more fluid, more likelihood. And then the nerve sensitivity during this period of time as well as those levels of fluctuation that we see in the glucose. So lots of reasons why this could happen. The good part about it is it does typically self-resolve as pregnancy comes to an end, and after delivery or potentially after breastfeeding, we don't see much need for additional intervention. However, if a mom is quite miserable or unable to really wait out that period of time or doesn't see the resolution, they do have some options for splinting or doing injections. When we're treating these different musculoskeletal disorders in the population, we do need to keep in mind that some of the modalities that are commonly used in rehab do have added precautions or contraindications during pregnancy. Many of them are related to the thermal risk. So again, we talked about neural tube defects as being a risk of increasing the environment around the core temperature. So things like heating pads, thermal ultrasound, diathermy, whirlpools, and hot tubs, all of those are on this list due to their connection to increasing temperature. Some of them are a little bit more due to just the natural intervention type of it, that it's a little higher amount of intervention and maybe don't have as much research related to the safety during pregnancy. So things like dry needling, blood flow restriction, traction, and stim. They're ones that we're kind of thinking as relative precautions because they don't necessarily have direct modality risk. However, they're not as well established as being safe in pregnancy. So that helps us transition then to our postpartum. So delivery, ta-da, now we have a baby. And the mom is on a whole new process towards recovery. We know that that period of time is fairly ill-defined, right? So most women after delivery of a child will go in for a physician appointment somewhere between 6 to 8 weeks to get the kind of elusive return to activity clearance or return release from the office. So, although this period of time only lasts 6 to 8 weeks, we know that this doesn't align with the physiological and musculoskeletal return of the system. So, when it comes to the abdominal muscles, let's talk about that timeline. Is it 6 to 8 weeks where we usually see people get better? And by get better, we mean return to baseline. Totally different. It's not 6 to 8 weeks at all. What we see is that there are actually changes still functionally present and structurally present at 6 months postpartum. Partial recovery of diastasis recti can happen after childbirth, but it's really even often still incomplete 1 year out. So a lot of times when we're seeing patients in our clinic, we may not have indications that they're acutely postpartum. However, if you start to ask more subjective questions and find out that they have an 8-month-old, a 10-month-old, a year-old child at home, some of these changes that we see and some of these risk factors we see might be related to some of that incomplete muscle recovery. They've looked at trunk control and overall strength and saw that 40% of people in the postpartum period were at a grade of 3 out of 5 or less. So it's not just that they're slightly behind where we would like to be, they're significantly behind where we would want to be. And that fatigability is also a factor as well. So it's gross strength and it's overall endurance as well. So many factors of those abdominal muscles are still recovering far after the MD clearance to activity. What about joint laxity? Well, we've seen in the studies that actually joint laxity is still persistent after 6 weeks as well. So there is some of that increased ligamentous play even after a month or two following delivery. The good news in the cardiovascular system, our VO2 max is actually going to return to its pre-pregnancy level pretty much after delivery, as long as someone was continuing to be active during gestation. So one for the positive recovery category, cardiovascular would be in that one. And then just a couple other considerations to put in there with people who have vaginal deliveries. There is that chance that they will have lacerations in the perineum. So just thinking about how that plays into return to exercise. They're healing not just from a muscle contribution, but also from the actual trauma from birth. And then the considerations that go into a C-section. So women who have cesareans also typically have a pretty similar return to activity clearance timeline from MDs. However, their muscle trauma in the abdominals is considerably different given that they have an incision. So there is really not a lot of specific recommendations for women given a cesarean delivery. And that's something that you see a lot of rehab professionals really trying to change, is to offer more resources for women who have C-sections and how to recover from that more like a post-op patient and less like a vaginal delivery. And the research with that, it's in the pilot phases. There's some in the Journal of Women's Health PT. However, there really is a lot that can still be done. There is a professor at the University of Wisconsin-Madison, Jill Tyne-Nissenbaum, who has worked on trying to objectify the return to exercise progression postpartum. And this is some of the information from her information. So we've got the concept of treating a return to life and exercise after a child as similar to return to sport after acute injury. So thinking about this more as we would return like an ACL injury or return like a back injury, because really that is a lot of the same muscle recovery phases that we would be undergoing. So the specific recommendations that are laid out here are in regards to both dosing and progression. So progression-wise, starting with lumbar stabilization with really that attention to loss of form, right? We don't just want to be pushing through the reps just to get these high volume. If we're seeing that loss of internal stabilization and that anterior pelvic tilt as we're trying to do some of these. So really thinking about stabilization. In the dosing scheme right here, we see less than 70% of the 1 rep max with a 10 to 20 rep goal, with 2 to 4 sets being the initial target. That rest period will be 30 to 60 seconds. So in general, you can see this is more of an endurance paradigm. General frequency being 2 to 3 times a week. Once that has been well established and someone can do that lumbar stabilization, add on the extremity movements through the arms and the legs, then we can begin a strength program with the extremities, and we can also begin a cardiovascular program. So some of these types of exercises that you might be seeing people integrate next once they've got a successful lumbar stabilization program is biking. So biking requires some core stabilization, but not nearly as much as needed for swimming or running. So it could be an early return to exercise modality. However, we have to think about the logistics of the bike seat, right? People may have a lot more comfort on a recumbent bike versus an upright bike, or they could alternate between sitting and standing. You will likely see a difference in timeline, again, between a vaginal delivery and a C-section, because those abdominal muscles might take a little longer to stabilize after the cesarean. Swimming is the next one to discuss. So earlier in introduction, maybe 1 to 2 weeks. However, if there's blood loss, we may actually need to wait for that doctor clearance in order to have tampon use, which might not be until 6 weeks. And then if it is a cesarean, the incision has to be cleared in order to be safe for submersion. So some of those restrictions may be less related to musculoskeletal recovery and maybe more practical in terms of water submersion. Thinking about swimming though, you may want to recommend a buoy early on, because swimming is highly repetitive as well. So having that full range of motion with the repetitive stroke, you could have an increased risk of tendinopathy or tendinitises, given that overuse risk is there with the similar movement pattern over and over. So having a buoy might decrease some of the demand on the tendon, which could help early on. And then finally in this category is running, higher level of core demands, and really should be started as a walking program. I think a lot of people look towards running because of the weight loss potential that they see with running. However, we really want to make sure they're ready. We want to make sure that they have adequate lumbar stabilization, that they're really giving themselves an appropriate walking pattern first, and then can slowly transition some of those walking steps into running steps. And again, I treat my postpartum return to running patients the same way I would treat someone who's returning to running after a stress fracture or returning to running after they've been on some sort of restriction for knee pain. That's how we want to be thinking about these progressive loading patterns with return to running. There has been some data looking at the contrast between running solo versus running with a jogging stroller. It does show that if a jogging stroller is loaded between 20 or 50 pounds, that there are minimal changes in exertion, and that the mechanics are actually similar to solo running. However, as someone who has done a lot of stroller miles in my time, I would say that that seems like it would probably only apply in lab settings, because anybody who's pushed a jogging stroller up a hill or against the wind can tell you that there is definitely a little bit of subjective difference, plus that kind of constant need to feed someone a snack or answer questions means you might be talking or reaching or doing some interesting mechanics. I think we would kind of be missing the boat if we didn't at least talk a little bit about the pelvic floor, although recognizing that primarily most of us are probably not practicing in this setting. We just want some basic general concepts. So pelvic floor tips for the non-pelvic floor PT. Just remember the pelvic floor is part of the core, so we don't want to leave that out when we're returning the core muscles to their prior state. We don't want to hold our breath because that increases intra-abdominal pressure, which has the likelihood of increasing incontinence. So we need to be able to draw in that pelvic floor while still maintaining breath support. Keep in mind that we need to be functional across positions, right? We don't only strengthen someone's quad laying on a table. So we also need to strengthen their pelvic floor across positions. We might start a Kegel type of exercise laying on our back, but eventually they need to be able to do it in upright and weight-bearing positions as well. And then I think probably the most important thing is that we need to know when someone needs more specific attention, and that might be if they're unable to perform an isolated contraction even after cueing and education, if their exercise is severely limited by incontinence, or if they have pelvic pain or pressure during activity. Diastasis recti is quite common. That's where we've got the separation of the abdominals. We used to talk a lot about closing the gap, trying to get that linea alba to be tight, where really now what they talk a lot more is about getting that transmission of tension. So we really want the transverse abdominis to try and minimize the doming, or that kind of AP distension that we see, and we're trying to get it to flatten rather than getting it to close. And again, done with abdominal strengthening exercises. I do just want to take a second to talk about some of the specific considerations in this population. There's a lot of sensitivity related to body image, and there's a lot of stress and often emotional volatility related to weight loss and body changes. There might be some things with breastfeeding, either positioning or the caloric demands. Again, pregnancy is expensive when it comes to calories, but so is breastfeeding. And then be on that lookout for postpartum depression. It's really common, 10 to 20% of our moms will have that. And being that in rehab, we spend more time talking to these moms, we might be the ones that pick it up. And then just a quick case example we'll go through kind of briefly so you still get a good break. But a 38-year-old woman who presented in my clinic with intermittent sharp stabbing pubic symphysis pain post-running. She came to me 4 weeks postpartum with her second baby, telling me that she was going to run the Boston Marathon in a month. So she had gone back to running 2 weeks postpartum, about 10 to 12 miles at a time. had already started speed work after a week of running, and was really hitting the ground really aggressively, knowing that it was her last chance to run the Boston Marathon before she lost her eligibility due to deferrals with COVID and a previous pregnancy. She was not antalgic or having issues with regular walking. I was able to palpate without a lot of difficulty at that pubic symphysis. So no real concerns with infection or traumatic separation, anything like that. But she did have some pain with my clinic testing. Generally speaking, our treatment for her was to try and integrate strengthening from a really progressive way and to manage load at the same time as introducing graduated progression. So we were trying to manage her mileage and try and do it without irritating symptoms while also trying to build up both that hip and core strength. So generally speaking, we were able to get her back to running that distance in that amount of time. She did finish the Boston Marathon at 6 weeks postpartum. Pumped at the start line, pumped at the finish line, but overall got through it. All right, so we're looking at menopause in our third and final portion of today's course. So we'll dive right in now. All right, diagnostics. So really, what does menopause mean and how do we define it? So the functional role of menopause, it's the end of a woman's fertile life, so the end of their reproductive phase. It is really marked by that loss of the ovarian follicular function. And how we know that it's occurred is that there has to have been a 12-month period, a sequential 12-month period without a menstrual cycle. So once we've hit that, someone technically is defined as being menopausal. So it's really a retrospective diagnosis. You don't really know you're there until it's already happened. The timing of it in the United States, the average age is 51, but it's considered usually normal anywhere in the late 40s to early 50s. If you enter into menopause before age of 40, it's considered premature, but 40 to 45 would just be considered early. The process of achieving 12 months without that menstrual cycle usually is a process of 5 to 8 years of transition. And that period of time is either called perimenopause or the menopausal transition. That period of time is fairly ill-defined because it's hard to really identify when does it start. Early on, it's really still a mostly regular cycle period of time. And then as you're deeper and deeper into this perimenopausal phase, that irregularity and amenorrhea may last more than 60 days at a time, really working up towards that full year where there's no menstrual cycles to be considered menopausal. There are some factors that are associated with earlier or later onset, so the timing does have some influence on other things. When someone has a later age that they begin menopause, naturally speaking. So, of course, there are other reasons why menopause is begun, and it can be for surgical reasons, things like hysterectomies. But if someone naturally starts menopause and it's later, that is associated with a longer life expectancy. It's also associated with higher bone mineral density and lower fracture risk. It's associated with reduced all-cause mortality, cardiovascular disease, and cardiovascular death. So generally speaking, there are a lot of really favorable things that are associated with a later onset of menopause. However, amongst obese women, there is a greater breast cancer and ovarian cancer risk if they have later menopause. There are different categories associated with the age of onset. So those are some of the associations. These are some factors that actually influence when you will enter that period of time. So the first category is ones related to reproductive health. So at the age of menarche, we actually have a window into our age of potential menopause. So if someone has early onset of menarche, so before 11 years old, they might be more likely to have early menopause. If someone has really short cycles, so less than 26 days, they're more likely to have early menopause. If someone has more children, so higher parity, have more pregnancies, they're more likely to actually have later menopause. Then when it comes to weight and BMI, this is where we see some of that kind of crossover of groups. So if your premenopausal weight was higher, you have a higher BMI or waist to hip ratio, that actually can make your menopause delayed. So that's one of the ones we saw associated, if that's the cause, more likely to have ovarian and breast cancer risk. And then the other one related to weight is if someone is underweight in early or middle adulthood, or they have really low BMI, they may have earlier menopause. We see that people with higher cholesterol, higher blood pressure, and other cardiovascular risk factors, that they're more likely to have early menopause as well. And then smoking, specifically cigarettes, is also linked to earlier menopause. So a lot of these are actually somewhat modifiable when we look at which ones are fixed versus which ones we can control. Weight and BMI, some of these cardiovascular risk factors, and smoking are all modifiable factors. The hormonal changes affiliated with this period of time are really characteristic as well. So to start off the whole process, we've got this decrease in follicle numbers. So the follicle numbers, as they decrease, are going to then trigger this rise in FSH. FSH being follicular stimulating hormone. There's less follicles, so our hormones are going to elevate to try and trigger more. This is also, though, paired with the fall in estrogen, which we know now to be estradiol, at the same time. So we see FSH rising and estradiol falling. These are the two characteristic hormonal changes in menopause that we're going to really focus on in this section. Just as an aside, testosterone does decrease in women. However, that's happening usually outside of this menopausal time. We see that happen between the age of 20 and 45, and it doesn't really change during menopause. There are signs and symptoms galore in menopause, right? So if we thought that pregnancy had a lot of changes, I think menopause has probably just as many. They're just a little harder to identify in someone walking down the street. The first category is vasomotor. So these are ones like hot flashes and palpitations. There are psychological symptoms like mood changes and depression, irritability, anxiety, sleep disturbance. We've got cognitive symptoms like memory issues and concentration, and then atrophic effects like vaginitis and bladder irritability. So really lots of different systems, lots of different potential manifestations. I wanted to spend an entire slide on hot flashes because really this is the hallmark symptom because so many people experience them. If we thought 60% of women having back pain in pregnancy was almost everyone, 80% of women in menopausal transition are going to have a hot flash. So huge amount of the population is going to go through these vasomotor symptoms. There are some factors with that, hormonal factors, of course. Obesity prior to menopause, cigarette smoking, and higher levels of anxiety and depression, and lower levels of education. Those are all factors in this onset of vasomotor symptoms. There's not as much data associated with hot flashes and physical activity or diet or alcohol. However, there is some kind of mixed evidence. But just when you thought you talked through all of the symptoms, there's more. They just keep on coming. It's like the gift that keeps on giving. So there's night sweats, headaches, fatigue, libido changes or changes in pruritus, and then as well as back and muscle pain. So lots of different things that can be affiliated with this. The thing that's kind of interesting, we'll talk about it as we go through, is there's symptoms related to menopause. That's this green one. But we have to tease those out from symptoms that are related to aging, that are independent of the hormonal changes. So some of the things that we see as we go through this phase of life are actually more related to age than they are to the hormonal status. And as we go through, we'll try and kind of identify which ones are more related to age and which ones are more dependent on this transition. As we talked about through menopause, there are changing hormone levels, and that does also correlate with this increase in risk of chronic conditions. So during this period, we see higher rates of cancer and diabetes, autoimmune disorder, osteoporosis, and cardiovascular disease as well. How do we address then the patients who are dealing with these symptoms? Is there anything that we can do to help? Truly, the one that is the most effective for symptoms is hormone replacement therapy. Now, this is the use of synthetic hormones, which can either be estrogens and progestin, or in the case someone's had a hysterectomy, it's going to be estrogen alone. And this is going to be used to really try and replace some of that hormone deficiency so that we have a reduction in some of the symptoms. And although it may be effective for treating the symptoms, it does come at a risk. So there's been an increased risk of breast cancer, which is why there's been some reduction in how readily this has been prescribed. However, when they did estrogen alone without the progesterone, it did not have the same increase in breast cancer risk. However, there was a trade-off because it did have an increase in stroke. So the symptom profile and the risk profile is really a balancing act of whether or not someone is going to be prescribed hormone replacement therapy. And we're going to leave this one kind of standing, this increased risk of heart disease. We're going to talk about a little bit further on because it's not just a yes or no. It's actually an it depends. Other than hormone replacement therapy, there are some alternatives. Currently recommended are physical activity and exercise. There's a lot of studies looking for more, but so far they're not necessarily universally recommended, although you might still see some people try them, right? So things like ginseng or red clover. It's not on this list, but I think we'll probably see it added to the list in the future of things like CBD. When it comes to having exercise as a recommendation, the question comes back to kind of what's first, less menopausal symptoms or more physical activity? It's like a chicken and an egg question, right? So when we see that people are more physically active and that their mental health seems to go up with that, what we don't know is it because of the positive social interactions, or is it they're actually getting more resources to alleviate their symptoms? Is it counteracting the negative influence of menopause symptoms or depressive symptoms? We kind of have this balance. We don't necessarily know how and why. We just know that when we have more activity in menopause, we tend to see more favorable symptom profile. So they have tried to study this specifically. They did a 16-week exercise program and compared it to a 16-week educational program on psychological well-being. So both of them were in group settings and had either physical exercise or education. The exercise group worked for 60 minutes concurrently, so doing it together, aerobic and resistance training, 3 times a week for 16 weeks. And then the counseling group, or this education group, they attended conferences on healthy lifestyles with things like diet, physical activity topics, but didn't actually physically exercise together. The outcomes that they were really measuring were these positive and negative affect schedules. So on these schedules, the higher the score, the more of that emotion that was present. So higher affect score, higher positive affect score was more positive, good emotions. So you want the positive score to go up, and the negative score you want to go down. So in the exercise group, what they saw was that the positive affect score increased by between 3 and 4 points, which is what you would hope for, is for it to go up. And the negative affect score decreased by over 4 points. So you saw the positive go up and the negative go down. In the counseling group, they saw the positive scores actually decreased a little bit between 0 and 1 point, and the negative score also went down similarly between 0 and 1 point. So essentially, both groups saw some kind of changes, but really the exercise group saw significant increases in positive affect and significant decreases in negative affect. Body composition. This is a really big topic in menopause because we see a lot of women go through a major transition of their body composition, and then they have to readjust to this new body shape and this new way of function in their physical self. So this is a little bit of that teasing out menopause versus age. So we see that age itself, so just purely time, is responsible for an increase in obesity. So if we have someone who is 50 years old and menopausal versus someone who is 50 years old and still in the transition, both of them we would expect to have an increase in obesity by age alone. The thing that we do see is that in menopause, there's actually a difference in the distribution of obesity. So we see an increase in truncal obesity and visceral adiposity, so kind of that central weight gain, and the simultaneous loss of lean body mass. So we see that kind of decrease in lean muscle and that increase in visceral or central adiposity. There are some ethnic differences. We see that the patterns between African American, Caucasian, and Asian have different patterns of kind of when the body composition is changing and how it continues to change in different phases. So it's not a universal experience globally. There are some connections directly to estrogen and how this plays in. So there are metabolic changes that come from lipid metabolism and energy consumption and insulin resistance that is directly tied to estrogen. We also see that the actual body shape is related to estrogen as well. So when we're talking gynecoid versus android, we're talking pear-shaped versus that more apple shape being what happens more when we're in the menopausal transition or postmenopausal. And then we know that this type of body shape is increased risk of cardiovascular disease and metabolic concerns. There isn't, though, all the credit just to be given to estrogen, because we also see a role of FSH, or the follicular stimulating hormone, because this also stimulates fat distribution and contributes to pro-inflammation. So we've got estrogen kind of at the top of this list, giving us some of these things with metabolism and insulin and body composition, but FSH is also having a contribution in this role. We know that when we do have these cardiometabolic risk factors, that the mortality and the overall health in some of these systems will falter. So abdominal fat can be a factor in insulin-resistant type 2 diabetes and lipid panels, abnormal lipid panels. The mortality risk is 4-fold increase in postmenopausal women who have an obese BMI. But what's interesting about it is that it's not only our postmenopausal women who have obese BMIs who have these increased risks. We also see these increased cardiovascular risks in non-obese postmenopausal women. So part of that comes down then to how do we screen for this? Because if we're not using BMI as an accurate cutoff for who should or should not be screened, we may need to find a different way in order to identify and catch this. Some of the suggested ways to do it are either having a lower BMI threshold for menopausal health screening, or using a different characteristic altogether, maybe a waist circumference or a waist to hip ratio or body shape index, something like that, that might actually sidestep the difference in general overall weight versus distribution of weight. Because if you gain 20 pounds of visceral adiposity, but you lose 20 pounds of muscle, you're not going to look on paper like your BMI has changed at all. However, your general cardiovascular risk profile has. The way that estrogen factors in specifically to energy intake is a little bit more in depth on this slide. So we're talking about how estrogen actually has an inhibitory effect on appetite. So as our estrogen levels then are decreasing, we have less inhibition on appetite. So that can be a central control to our overall intake. When it comes to cancer risk, we know that obesity is risk associated with some of the malignancies, including endometrial and breast cancer. But one of the specific statistics that I think is quite striking is this one about how many risk points per how many pounds, or in this case, kilograms. And it's saying that your postmenopausal breast cancer risk increases by 11% for every 5 kilograms. So just roughly speaking, if we were to say 5 kilograms is about 10 pounds, about 10%, it's about 1% per pound that our risk of breast cancer increases as our weight increases. So then let's talk about weight management, right? Because that should be our first question. If weight is a risk factor in these things, how can we decrease our risk? So, weight management. What we have to kind of think about is the role of diet versus the role of exercise. What we know is that dieting alone is actually an effective approach to initially lose weight. When they compare a study group who diets and a study group who diets with exercise, there is essentially an equivalent amount of weight loss. So there's not a ton of weight loss benefit initially to adding exercise. However, what they have found is that those who exercise along with weight loss with diet will have increases in lean muscle mass. That lean muscle mass is more expensive calorically to have. So the body has this higher basal metabolic rate, higher general energy consumption needs. So after we maintain this new weight, we're more likely to maintain weight loss in the group that has also completed exercise. Those who merely diet are more likely to gain weight back. So if we kind of think about how to pitch exercise to our clients, we should be telling them that it's not about losing weight. It's about maintaining weight loss. And I think that can be a really helpful thing when we're trying to set expectations. Strength is not only important for weight loss, though, or should we say maintenance of weight loss, it's also important for function. Decreased strength isn't a determinant of overall impaired functional capacity. This includes fall risk, increased mobility disability, osteoporotic fractures. All of those are associated with decreases in strength. So if it's not for weight loss, we overall need this for general function. What we see is that muscle strength actually begins to decline during perimenopause. Yes, this is partly estrogen dependent. So we know that there are estrogen receptors in the musculoskeletal system when we have less energy or less energy as well, but less estrogen. We also have some of this sarcopenia that's coming in. However, that's not the full story. We can't just say it's estrogen dependent. There are also modifiable factors that are contributing to this sarcopenia. Part of it is inactivity. There tends to be a decrease in overall energy expenditure. There's also generally a decreased protein intake during this period of time. So we've got this kind of perfect storm of decreased estrogen, decreased activity, decreased protein, decreased muscle mass. The good side is, though, It's not set in stone. It doesn't have to stay that way. So, exercise has been shown to actually improve postmenopausal muscle performance and strength. So, if we're embarking on these strengthening programs in the postmenopausal period, we may have to modify how we're doing it to kind of meet our new body system, but we should see the strength gains that we're looking for. Women who are on hormone replacement therapy may see bigger effects as well when they have this estrogen replacement. The specific American College of Sports Medicine recommendations for strengthening in older adults over the age of 65 are what are presented to you on this slide. And what we'll see is that really we should be treating older adults a lot like we're strength training in younger populations. Although what we're seeing is that even some is better than none. So to enhance muscle strength, the recommendation is that there's at least one set of 8 to 12 reps. 8 to 12 reps for a single set is an incredibly achievable amount of exercise for most populations. They do also acknowledge, though, that 2 or 3 sets is likely more effective than one, but kind of the best point is let's start somewhere and let's build up from that. It should be progressive. We want to find that it's progressive either with weight or number of sets, number of reps, or the number of days a week. Generally speaking, we should continue to build. We shouldn't just kind of accept the status quo. When it comes to how much load is appropriate, the muscle strengthening types of exercises should be done to the point where it's difficult to do another repetition, right? Just like we would train in other populations. So when it comes to kind of strength training in this group, it's not uncommon to see kettlebells and bar and plate exercises. It's possible. We just have to work up through it progressively like we would any other population. When it comes to tendinopathy in this group, it's something that I wanted to talk about a little because I've seen periods of time in my practice where I get like batches of women in this period of their life, all with tendinopathy at the same time. And it made me ask the question of why is this happening? And what's kind of interesting to find out is that estradiol, or the estrogens that we've been talking about, they play a role in maintaining the homeostasis of female connective tissue. So essentially, it's not that after menopause we have this skyrocketing greater increased risk of tendinopathy than men do, but prior to menopause, women actually have a protective effect from estrogen of tendinopathy that we just kind of lose our advantage earlier on. So, generally, that kind of leads us to a point where our risk of tendon rupture and pathology ends up equaling out to what men have after menopause. Part of the estrogen receptors that we were talking about in the musculotendinous unit actually come in the tendons themselves. So we know that there are estrogen receptors, that estrogen plays a role in tendon health. But we also know that tendons have higher likelihood of undergoing these degenerative processes depending on body shape. So these android body shapes have higher risks of tendinopathy. And we know that in menopause, we tend to transition from those gynecoid to android body shapes. So those factors kind of stack on top of each other. So let's then kind of circle back to cardiovascular disease. Cardiovascular disease is the leading cause of death in women. So although historically it has always been talked about more in the male population, it is still a very prominent topic to be talking about in the whole overall population because it is very common in women as well. And this is a time, the menopausal transition, where there's an accelerated cardiovascular disease risk, which makes it, by nature, a critical window for implementing early intervention, right? We shouldn't be waiting for women to have heart attacks to be talking about what they can do to improve their overall cardiovascular health. I found this statistic honestly fascinating and also really eye-opening. When they did these studies, they found that only 7% of women in perimenopause met the physical activity guidelines. 7%. So that meant that 93% of women could improve their physical activity profile in order to improve their cardiovascular risk profile. So exercise is a huge untapped way to try and improve overall health and mortality risk. Then similarly, less than 20% consistently maintain what they consider a healthy diet. So again, less than 20%. That means 80% of our female population in perimenopause can utilize dietary improvements as a way to improve their cardiovascular risk and overall mortality risk. So really, really accessible, safe, inexpensive ways to change our overall health in our female population in this phase of life is kind of on the table. These are specific menopausal factors that are associated with the cardiovascular risk of disease. So earlier age of menopause is linked to cardiovascular disease. There are racial differences and ethnicity differences. Having shorter menstrual cycle lengths also is linked to cardiovascular disease. Lower parity, so again, less pregnancies. Smoking, probably not surprising to anybody at this point, or surgically induced menopause, such as having your ovaries removed, is also linked to cardiovascular disease. So these very female-specific characteristics, with the exception of smoking, are specifically linked to cardiovascular disease risk. This is the one where we want to talk a little bit about the changes related to the system and what happens during this period of time. So we know that there are changes in pericardial fat volumes, that they get higher after menopause. We know that there are increased lipids during this period of time as well, like those LDLs, which is driven more specifically by menopause than it is by age. So again, difference between age versus menopause. So LDL, those cholesterol changes, more related to menopause. Ones that are more related to age specifically and not necessarily hormone would be blood pressure and insulin glucose. Those are more related to age. And we do also see a reversal in the HDL relationship. So earlier on in life, we see that HDL levels, having them high, is helpful for cardiovascular disease risk. However, this changes during perimenopause. So preventative measures overall for cardiovascular disease in menopause, of course, some of them we already talked about, right? Weight loss and dietary changes and physical activity, of course, we should be doing those. Those are kind of no-brainers. Smoking cessation, probably put that on the list as well. But then there is a potential preventative measure through hormone therapy. So this is the question mark one on an earlier slide when we talked about hormone replacement therapy. There is a varying effect on the cardiovascular system with hormone therapy based on when you have it and when your onset of treatment is. So it's been shown that there's actually a beneficial effect on cardiovascular outcomes and mortality when hormone replacement therapy is started earlier. So less than 10 years since menopause or under 60 years old. However, if hormone replacement therapy is started at older ages or longer removed from menopause, then it can be kind of neutral or actually have harmful effects on the cardiovascular system. So again, kind of thinking about when are we looking at implementing it, what are our risk profiles, but hormone therapy may actually have a slightly protective effect on the cardiovascular system. And then that brings us to osteoporosis. So osteoporosis is really important to talk about in this population because of the incidence of it. We have more than 10 million Americans over the age of 50 years old who have osteoporosis. And in addition to those 10 million, another 34 million are at risk, right? So there's osteoporosis, but then there's also osteopenia, or that kind of precursor to osteoporosis. So the total amount of people in this category of osteoporotic or porotic risk is really high. And one of the reasons why it matters is because of these fragility fractures. So 1.5 million fragility fractures happen each year. I've probably talked about in other courses, I'm married to an orthopedic surgeon. It is very common for him to operate on 5 or 7 or 8 hip fractures a weekend when he's on call because these fragility fractures are happening all the time. The bone mineral density is really the defining characteristic of osteoporosis. It needs to be greater than or equal to 2.5 standard deviations below the average for a young, healthy woman. That's how the definition of osteoporosis would be diagnosed. The estrogen deficiencies that happen after menopause really accelerate any age-related loss of bone. So over time, that age is going to relate to bone loss. However, once the menopausal estrogen deficiency happens, that's where we get that acceleration. The osteoporosis measurements are typically taken at the hip and spine and are taken using an imaging technique called DEXA, which is the dual energy X-ray absorptiometry, which is that gold standard for a diagnosis of osteoporosis. Many populations rely on DEXAs, whether it's looking for osteoporosis or looking for like bone density concerns in the female athlete triad, like we've talked about earlier, or in RED-S. The DEXA is something you'll probably hear about, but if you've never had one done, this is kind of an explanation of that. And DEXA takes about 10 to 30 minutes to complete, and it uses low-dose X-rays with 2 different and separate energy peaks that get sent through the bone. One peak gets absorbed mostly by the soft tissue, the other one gets absorbed mainly by bone, and then these two are compared. So the soft tissue amount subtracted out, and then what remains is the bone mineral density. And this is all calculated by software, so an MD is not over there or a technician over there calculating things, and it's given an output. The resultant score is either a T-score or a Z-score. So the T-score is going to be that bone mineral density compared to young adults of the same gender in peak health. So that's the one that we use to identify osteopenia or osteoporosis. The alternative is to get a Z-score, and the Z-score is used oftentimes in younger people who are still growing when they're comparing bone mineral density to someone in the same kind of matched age and gender. If someone is more than 2 standard deviations off of their Z-score, that's when they're probably going to do some follow-up testing in order to look at that more. Osteoporosis, though, is more than just bone mineral density. So density is a factor, but it's also going to be partially due to the architecture and the size and the shape of the bone. So there's material properties and structural properties. And fragility will depend on that combination of both. The risk factors fall into these 2 different categories. We've got modifiable on the left and then also non-modifiable on the right. So things like weight and smoking and alcohol consumption, those are all things that we can adjust in order to try and decrease our osteoporotic risk. We commonly see physical activity and dietary calcium or vitamin D being ones that are being addressed in the modifiable category as well. Long-term glucocorticoid use is also going to be a risk factor for osteoporosis. Non-modifiable things, so the female gender and older age, of course, both factor into that. There are different race and genetic characteristics that go into higher risks of osteoporosis. And then anyone who had premature menopause, they may also be more likely to further develop osteoporosis, which goes along with those who have the loss of ovarian function before menopause. We get this very characteristic Dowager's hump, which we see a lot of people will come in our clinics and say, that grandma hump in my back, right? I want to try and avoid that grandma's hump. That is from the compression of the vertebral bodies, creating that increased and excessive thoracic kyphosis. Because of that decreased vertebral height, we will see a total decrease in body height. So someone who goes into the doctor and has always been 5'4" might suddenly be 5'3" or 5'3.5", and they lost a half an inch. That may be indicative of some loss of vertebral height and compression. Bony fractures might be one of the things that cues someone in to notice that they actually are at risk or having some of these bone density concerns, either spontaneous fractures or low velocity or low amplitude mechanisms causing fracture. And then another symptom or following effect could be that respiratory impairment. So if somebody is getting this difference in their thoracic cavity, they may have less functional space for their lungs to function. So the treatment can fall into a couple different categories. The first one we'll talk about is pharmacological. So pharmacologically, we most commonly see that the drugs are targeting inhibition of the bone resorption. So these would be our things like our bisphosphonates or our denosumabs, but there can also be medications used to try and stimulate bone formation. They're just less common. There are non-pharmacological interventions as well, which we'll see very commonly: calcium and vitamin D supplementation, having conversations about coffee and smoking or alcohol. But then this bottom characteristic or categories on balance training and exercise. So exercise can actually be used to try and stimulate bone growth, but then balance training is to try and limit falls. So we're trying to limit the risk of osteoporotic fragility fractures while also trying to improve their muscle strength in order to improve their coordination and resiliency, while still stimulating bone growth as well and bone density increases. The Bone Health and Osteoporosis Foundation has some recommendations on exercise, and they talk about having high or low impact exercises, and also doing muscle strengthening exercises. So some of the ones that they have on there that are lower impact may or may not truly lead to increases in bone density, but may lead to overall muscle and strength benefits that may otherwise be beneficial in other ways. Because we know that there is a difference in modality of exercise to impact on bone. So things like walking don't really have much impact on the prevention of osteoporosis. Similarly to swimming, they really have little or no effect on bone mineral density, but our higher intensity and weight-bearing exercises do have more direct impact on that. So just kind of a consideration of what is our overall goal. If we're looking for cardiovascular health, if we're looking for balance and coordination, muscle strengthening, that's one thing. If we're looking for true bone density formation, then we need a little bit more of that higher impact. There are a couple of things we want to avoid when it comes to people with osteoporosis. One of them being falls, of course. So thinking about the slipping risk, the tripping risk. So this is really watching our rugs, watching our step heights. But we also want to avoid resisted trunk flexion. So one of our classic mechanisms of injury for a fracture of the vertebral bodies of the spine is the opening a window. So where a woman reaches forward to lift up the window, and that amount of pressure and flexion will create a fracture of the vertebral body. So we're trying to prevent that repeated or resisted flexion. So things like sit-ups and toe touches are ones that we probably don't want to repeatedly encourage in our exercise program. And then we'll just touch quickly on the socioeconomic influence of menopause. It's really not a universal experience around the board. Women are often fairly undereducated on what their expectations, what their process is likely to be like in menopause. It's something that usually women are kind of left more to crowdsource their information about. So oftentimes this isn't going to be our evidence-based research, right? It's going to be what Muriel at the YMCA said, or it's going to be what someone else heard from someone else who was at the Christmas concert last week. It's going to be things that are maybe not as rooted in our genuine medical evidence. We also know that socioeconomic privilege factors in because the poor in this case are often undertreated or have less access to care. The woman's actual perception of menopause is also likely influenced quite a bit by her community. Some communities and cultures see the menopausal transition as being a loss of reproductive years, a loss of femininity and youthfulness, a decrease in beauty, where other cultures will have celebrations of seniority and community and really rally around this as being a time where they're really gaining status. So a woman's self-reflections on this period of time will likely be quite rooted in their cultural norms as well. So a quick case example to really highlight this period of time is a patient of mine from about 3 years ago. She was a 65-year-old woman who came into the clinic with a 3-week history of right lateral hip and leg pain. It began after starting a new exercise routine, which she was doing with a personal trainer. There was really no acute mechanism of injury. Really, it just resolved everywhere but her hip after she worked out. So she didn't really have a reason to point at that this had happened. She had a lot of pain with walking, some with stairs, and it was about 8 out of 10 at its worst and 3 out of 10 just on exam. So her medical history did include a glute med min repair from a complete tear on the contralateral side 3 years before, which definitely contributed to some baseline levels of anxiety for her, thinking of the similarities to her other hip. Luckily, I didn't see any overt signs that I had red flags for complete tear. She had no postural deviation. She ambulated without an antalgia or in Trendelenburg. She didn't compensate in Trendelenburg either. She did have strength. She could perform anti-gravity motion. There was just pain associated with it. She could complete single leg stance and some squats without a significant weight shift. And there was no atrophy notable. So at this point, her diagnosis was much more consistent with glute tendinopathy than it was a tear. So we were able to start off with some isometrics. We did them both standing at the wall and on the floor. Did some self releases of trigger points using my favorite cotton dryer ball is what I love for glute releases the most. It's just hard enough with still allowing people to sink into them and get a good release. We did some manual therapy for trigger point release as well and reviewed her gym program. By visit 2, she was significantly less painful. We got to go through some mechanical education on hip shearing and having a reduction in that kind of lateral weight shift that happens in a lot of weight bearing activities that we see, especially in women. And by visit 3, she was returned to her baseline activities with essentially very low levels of limitation. So at this point, we discharged her from care on visit 3 and told her to continue to strengthen and progress her program to include things like bridge progressions and lateral planks. So that brings us to the conclusion of today's content. So in general, women have unique physiological considerations for exercise, and this is across the lifespan. So by widening our understanding of these distinctive characteristics, we can better educate our patients, we can improve our female health, and we can provide more effective care. So hopefully you took just a couple little nuggets away from today in order to be able to treat this population, or maybe even for yourself, a little bit more effectively. How does strength training look different for young girls at different ages? It's really important to have the discussion on how we integrate this for kids at different ages because it really will take on a whole different form depending on if you're working with elementary age girls or if you're working with middle school or high school age girls. So, part of what that conversation comes down to is there an age that's too young? And really, when we're talking about strength, I think really the answer is probably not. There's really no such threshold as too young because if you are adapting the strength training to meet their developmental age, strength is a good thing at any age. So even if we think before sports start and we're talking about toddlers and babies, strength training at those ages comes in with major milestones. So they're learning to sit, they're learning to crawl, they're learning to walk. And all of those things really are strength training for our littlest people. So as they start to age and they start playing youth sports, I mean, youth sports now is starting in, pre-K ages. A lot of times kids are starting sports at 3, 4, and 5 years old. So at this age, strength training really still is going to look a lot like play-based games. So strength training and I myself have a 5-year-old daughter. So if I was thinking about ways that we could integrate strength training for her little 5 and under soccer team, it might be games like doing wheelbarrows where they're on their hands walking across the field and their friends are holding up their feet and walking across. To them, it's just a game and they're going to have a lot of fun playing that, but we know that it's going to be working their core strength, their upper body strength. It's going to be working a lot of that full body coordination. So at those really young ages, like that pre-elementary school or early elementary school, we're really just going to do it through things that don't feel like strength training for them. Things like hopscotch and jumping is really great for the strength through the quads and hamstrings, calves. Jump rope is strength, even though it oftentimes feels like cardio for a lot of the kids. We're talking about things like monkey bars are great for strength training, even things like climbing trees. And really, what it comes down to is variety, right? If they're doing the same one sport activity all the time, they're only going to be strengthening the same muscles that go into that play. Where if we start to look at giving them variety, then the different muscle groups are going to come into that as well. So for those youngest kids, we can really approach it that way. As they get a little bit older, and we're looking at maybe the late elementary school to early middle school ages, that's when we can start to make things look a little bit more like dedicated exercise. So we might be doing things like step ups or side step downs on a stair in order to get some knee control mixed with quad strength and hip strength. We might be doing some band work where we're walking sideways and we're having them do those monster style walks in that late elementary school, early middle school age. Other examples might be things like for upper body, talking about exercises like push-ups or pull-ups, doing things like squats and lunges. All of those are really appropriate to start adding in when we're in that age range. And then when we're talking about our older young girls, so our upper middle school, our early high school, it makes a lot of sense to actually be doing things at this age that are more structured like a gym program. So doing things on exercise machines, either the set resistance cardio, or I'm sorry, strength sets that they have at the gym, or doing things with free weights, or starting to actually add load to their exercises are really appropriate at this age as well. And you'll see that as the team structure morphs throughout these age spans, that it's really natural that some of this stuff starts to happen, but just matching their developmental age with their strengthening program, I think, is a way to really set them up for success. Is there a way to objectively measure a female athlete's knee mechanics? So in the adolescent section of the course today, we talked a lot about the female athlete knee mechanics and how they change from late childhood to early adolescence, and how they go from being a little bit more like their male counterparts, where we have ideally more optimal mechanics and more neutral alignment, and then how after puberty we start seeing more of the genu valgus and the hamstring quad deficiency in that ratio, things like that. So it is something that we might want to quantify, especially when we're trying to identify someone's risk of re-injury. And there actually is a great tool that hasn't been around as long as some of the others, called the QASL, the Qualitative Assessment of the Single Leg Squat. And it's a great tool in order to give a numeric score to what we see mechanically. So when we're talking through the QASL, you take them through a series of tasks, and it goes from single leg standing to single leg squats to single leg hops. And during those 3 tasks, the athlete gets scored on a variation of different body parts and mechanics. So, for example, up at the hip, you get a point or no point based on whether you have a level pelvis or whether you have that adduction through the hip. There'll be a point or no point based on the adduction angle of the femur, and also for that rotational component of the kneecap. So those will get a point or no point based on the mechanics for that. There are also scores for things like lateral leans for compensations or losing their balance. Those will also be quantified in that test as well. And then there are some points assigned for how they hold their opposite leg for stability into the limb of interest. So these will be scored on the left side, they'll be scored on the right side, and then there'll be a composite score that's added together from all of these different mechanical considerations to actually give a number to an athlete's knee alignment and mechanics during a single leg squat or a hop. So generally speaking, a lot of times these mechanical things are more subjectively relied on from a rehab provider or therapist's expertise. But this tool allows you to have a score, have a test, retest over time. So you can also take a look at whether someone's intervention and training is making a difference. So it's great if you're trying to really show an athlete that what you're talking about is objective. It's also a really useful tool for coaches and physicians to be able to see where someone is at, because we have other tools for things like strength, right? We have manual muscle testing, but we also have isokinetic testing for strength. We have functional testing for things like the triple hop and crossover hop. But now this isn't just a quantity, but it's also making the quality more objective and measurable as well. What are some examples of core strengthening exercise that can be done safely during pregnancy? Pregnancy is such a challenge sometimes to hit the strengthening goals that we have because of the way that the body is constantly adapting, right? So something that might work in the first trimester may be very different than something that might work in the second trimester or the third trimester. So when we're talking about strength exercises during pregnancy, we really want to think about what part of pregnancy are we actually in, and go through it that way. So why don't we start with the first trimester then? So in the first trimester, a woman is likely not showing very much. She likely doesn't have a ton of weight gain or balance changes, probably doesn't have a lot of distension, or a huge increase in that lordotic curve yet. So strengthening can look a lot more like a typical strength program might. So a woman in this phase might be able to continue with some of their baseline exercises. So if they were doing things like planks, a woman in her first trimester likely can still perform a lot of those strength exercises like planks in this one. Other ones, you often can still do some of the ones towards your back in this trimester early on. A lot of those supine restrictions don't come in until after the first trimester. So you may be able to have them do some of the semi-reclined transverse abdominis activations with the leg movements where they're laying back, doing that posterior pelvic tilt and doing tap downs with the legs, or a static hold of the legs at 90-90. They might be able to do the dead bugs in that position as well, where they've got one arm going overhead in reverse of the lower leg. So again, that first trimester, you can be thinking about core strengthening exercises pretty similarly to how you would be thinking of them in other trimesters or in other phases of life. When we're getting into the second trimester, that's where we're going to start to see some of the supine restrictions. So we're going to need to get more creative about positioning. So if you are in that second trimester trying to avoid supine, they might still at this point be able to do some side planks, because the amount of space that's being taken up in the middle is still fairly moderate. They may be able to transition to a lot of quadruped core strengthening things as well. So we're talking about doing now, instead of dead bugs, we might be doing more bird dogs where they're on hands and knees, pulling that core in tight and going into alternating arm and leg extensions from that position. They might also be able to do some of their core strengthening from a position of seated or standing, where you're starting to add in some positions that work through the obliques and twisting as well during that second trimester. Then when they're into the third trimester, everything is kind of a whole new animal, because we've got more of that end phase of weight gain and body changes where we have balance challenges, and we have some of those postural modifications to deal with. So we might not be working against gravity as much in that phase. So when we're thinking about third trimester core strengthening, one of the ones that comes to mind to me right away is the Pallof press. So if you're familiar with the Pallof press, it's often done with a band or a cable column that's attached perpendicular to where the patient is. And they're going to perform a standing, or you could technically do it seated, or sitting on an exercise ball, doing a posterior pelvic tilt from that position, or activating the transverse abdominis and maintaining that as they grab the resistance from the band or the cable column and hold it steady. So it's a anti-rotation type of exercise where then they can be pushing out, pulling back in, pushing out, all maintaining core stability. So it's a really good one for that third trimester, because posturally they're upright. Posturally, they're in a really safe and stable position, but yet they're able to add resistance at the same time. Another option for the third trimester may be involving one of the exercise balls. So if they're sitting on an exercise ball, oftentimes performing that abdominal draw in maneuver sitting on an exercise ball, and then adding either upper extremity resistance using band pulls up like this, anchoring it under your feet, or using little free weights, little dumbbells, and doing alternating lifts or bilateral lifts, all trying to maintain stability on this ball at the same time, can be really good. Or you can have them use lower extremity perturbations if they're pretty stable. You obviously don't want your patient falling off the ball. So if you don't trust that they have a lot of stability, you'll probably want to guard them pretty closely. But sitting on a Swiss ball and doing marches is a great way to create core strengthening during that third trimester, where you're not having them supine and maybe not having them in those anti-gravity positions. Do you commonly see overuse injuries in women who have returned to exercise postpartum? The short answer to this one is yes. I think overuse injuries is probably something that the postpartum phase is the highest risk for, because at this point, we have a lot of stability to regain during that postpartum period. And in order to truly return to exercise and have the system be balanced and resilient, we have to come from a place of good stability. So it's actually really common for me to see overuse injuries in the extremities postpartum, when the true underlying root cause comes from the core and from the middle. A great example of this is a runner who I had. Let's see, she was probably 6 months postpartum, and she came in to me with ankle tendonitis. So she had, I think it was a peroneal tendon irritation that she was dealing with in her return to running program after having her baby. And again, about 6 months out. And in going through all of her mechanics and her evaluation, it was very clear that her greatest deficits actually weren't really related to the distal extremity, but that she had a lot of remaining instability through her core. So, interestingly enough, when we rehabbed her middle and actually restored her core stabilization, her distal tendon issues just self resolved. So, a lot of times I am seeing overuse injuries in women who return to exercise postpartum, a lot of tendinopathies, some bone stress injuries as well. And I think a lot of that has more of a central cause that is related to that midsection stability. So in that last part of section 2 today, where we are talking about return to exercise postpartum, it's really important that we're emphasizing that progression, the one that we referenced from Dr. Jill Tyne-Nissenbaum, where people are not just jumping right back into cardio exercise, but they're giving themselves that foundation leading into it of strength. It's really difficult for women in this phase of life to jump back into exercise in a balanced way, because a lot of them are using this for weight loss, or they're using it for other types of get themselves back goals, but they have really limited time. So if they're looking to try and get the biggest bang for their buck for exercise in the inconsistent life schedule that they have at that time, they may be really likely just to jump right to the cardio piece and just go right to running, right to swimming, right to biking, right to the things that give them the biggest sweat and the biggest caloric burn. But that's really setting them up for risk of some of these overuse injuries. How far out postpartum do you screen for abdominal muscle recovery? This question I love, because I feel like sometimes the answer surprises my patients. I tend to ask anyone in my sports medicine practice whether they've had kids, whether they're 23 years old, whether they're 43 years old, because the answer, I think, carries a lot of potential influence on the root cause of their problems for a long time. We know from that research that we talked about earlier in the second part of today's course that even 1 year postpartum, we don't see full recovery of the abdominal muscle wall and of the abdominal muscle strength and endurance. But we don't really know the threshold for how long out those things persist. And what I tend to see in a lot of the patients that I work with is that their acute deficits resolve over time, right? Maybe in a year or 2 years. But functionally, they tend to work around that deficit and actually tend to carry some of those with them long term. So I can think of women whose youngest child is 4 or 5 years old, who, when I go and do an abdominal muscle test for, especially those lower stabilizers, they have no idea how to find them or engage them. So when I'm doing this abdominal muscle screen, I'm still doing it probably 5 years out, maybe even more from children, because I don't necessarily assume that a woman has ever just spontaneously recovered it. And if they have, sometimes we still haven't found ways to integrate it into their daily routine. So they might be lifting or exercising and not able to purposefully or subconsciously use that muscle stability during their normal activities. What do you see as some of the barriers to exercise in menopausal women? This is a great question as well, because I see a lot of women come into my office, specifically in the fifth, sixth decade of their life, and really desiring to exercise more, but feeling like there are reasons why they can't. So I think some of the ones that are most common that I see are related to not knowing where to start. I think it was a lot different 10 years ago when people didn't have as much access to information. People didn't know where to go because they hadn't been told, or they hadn't seen what their options were. I think now some of what we get is information overload. We get information from our friends, from our family. We see it online, we see it in social media, and there's so much information out there that it can be really overwhelming to patients, and they don't necessarily know where to start, so they don't start anywhere. So I think sometimes actually being drowned in information can be one of the barriers. I think the other ones that come to mind are related to body changes. I think a lot of women who were previously active, who are trying to be mindful of exercise later in life, try and do things the way they used to, and then find it discouraging when that doesn't align with where they're currently at. So adapting to their current status, where they're at, meeting their exercise program with their current state, is also a really difficult thing for a lot of people. Um, and then also that point in life, it tends to be very full, right? It's menopausal, but pre-retirement. Work demands can be high. These might be working grandparents, so they might have roles in helping their children, in addition to also being professional and not having a lot of time.